Hello everyone, my name is Amanda, and my name is Sean, and today we're going to talk about childhood depression, specifically from a study from Troell et al., which was an article published in 2007. It focuses on two different types of therapy styles. The two different types of therapy styles were individual psychodynamic psychotherapy, IPP, and family therapy, FT. The study focused on treating depression in both children and younger adolescents. The reason why they did this is because these two groups hadn't really been studied and related to these two therapy types, which is why they decided to go ahead and compare them. Also, just to let you know, this study did not have a placebo group. And the reason why is because there were some people who might have been taking SSRIs or antidepressants, which would put them at a high risk for this age group, and therefore they just decided to exclude them from the study. The research question was, what is the clinical effectiveness of either therapy styles in treating moderate to severe depression in children and young adults? They had three hypotheses. One is that IPP would be effective, and after the treatment, they would have continued benefit from this. Second, FT would be an effective treatment for therapy. And third, IPP would be more effective than FT for treating depression. Next is our method section. So first, they had collected a bunch of participants, about 72, age range from 9 to 15. And they decided, after they collected them, to put them into two groups, IPP and FT. But the way that they were collected, though, is they had used the community child mental health services as a referral. Then they decided to filter them based off of criteria. First, they had used the Child Depression Inventory, which is a brief self-report measure. If they had scored greater than a 13, then they had met the criteria for major depression disorder and or dysthymia on the Kitty's SADS test. Another requirement was that children had to live with at least one biological parent, and they had to not take any medication for at least 4 weeks prior to the study. So after they had done the filtering, they were only left with 24 cases, a very small number. They broke them up into two groups. IPP had 11 cases, and FT had 13 cases. So in IPP, and even FTP, the processes were very different. For IPP, they had 16 to 30 50-minute sessions. Then for FT, they had 8 to 14 90-minute sessions. So they varied in length. But they did collect the data at the same intervals, though. The first one they had done was at a baseline. The second one was at the end of therapy. And the third one was at the 6-month follow-up. And I'll go ahead and tell you what the measures look like. The first one, they did a demography interview to figure out who the participants were, their background, etc. The next one, they had 3 self-reports that they had to do. The children filled them out, and it talked about their mood, their behavior, and their feelings. One of them they did was the Kitty's SAD assessment. The next one was a childhood depression inventory, the CDI. Then they had the moods and feelings questionnaire, the MFQ. And then lastly, they had the Children's Global Assessment Scale, the CGAS. It's basically for clinicians to assess and educate children on how their feelings affect their daily functions. And they collected those again at 3 intervals, the baseline, end of therapy, and at the 6-month mark. So now I'm going to talk more specifically about the measurements. They had the independent variable as the type of psychotherapy, IPP, or FT to see what was better. The dependent variable is the effectiveness of therapy in treating moderate or severe depression in children and young adults. They wanted to see between the both of them. Next, with the measures, they had used a mixed model repeated measure, ANOVA. Basically, it was used to examine the extent of depression as measured by the 3 continuous instruments, the CDI, the MFQ, and the CGAS. And they did those again at the 3 points, the baseline, end of therapy, and follow-up. And they wanted to measure all of those. On the second part of the analysis, they did a multi-level modeling, which was an ML win, to examine, again, the CDI, the MFQ, and the CGAS, to examine factors related to improvement of each of the therapy groups and focus on that. All right, so after the analysis was finished, it looks like the results were incongruent with the hypotheses, and so both therapy styles were effectively reduced symptoms of depression in children and young adults. However, the IPP therapy was more effective than the family therapy. Interestingly, there were 4 lost to follow-ups, which were included, meaning 4 participants completed only 2/3 of the study and did not do the 6-month follow-up. So the team had to do 2 different analyses, one including the 4 lost to follow-up cases, and they were just labeled as not treated, and then 1 analysis without them. The below table is the analysis including the 4 lost to follow cases. It shows all 4 types of depression: general depression, major depressive disorder, dysthymia, and double depression and it looks like both therapies were effective. IPP was significantly more effective than FT in their analysis. And however, when these 4 lost to follow-up cases were excluded, the overall effectiveness of both therapy styles had non-significant differences, which would indicate that these 4 cases had a significant impact. Next, I'm going to talk about the strengths of this study. The study provides evidence supporting the use of both IPP and FT in this age group, which is great because it adds both therapy styles to the list of treatment options that doesn't necessarily need to risk oneself using SSRIs or antidepressants to treat moderate to severe depression. Second, trained therapists can effectively deliver these focused therapies with the help of manuals to ensure that they follow IPP and FT styles exactly as intended. Because these styles are both proven to be effective, these manuals can also help to make sure these treatment styles can remain effective therapies. Third has to do with client diversity. Another benefit of this study is that it's conducted in 3 different countries. They did one in London, England. They did another one in Athens, Greece, and another one in Helsinki, Finland, all with varying cultural norms, values, and was still effective. Now I'll move on to the weaknesses. First, it was a very small sample size, including only 24 participants out of the 72 screened, which would impact how they would test the evidence in the study. Another impact would be the 4 lost to follow cases, which had an impact on determining the power analysis. Reason being is if the 4 cases were all in the family therapy group, it would make it harder to determine which study was actually better than the others in the result and findings. Next was the absence of an untreated control group limits the study's ability to prove with certainty the validity of therapies provided. If added, it may change how we see the data, and this is a consideration for future studies. And here's our works cited. Thank you. All right, now for our therapy session, we feature... Oh, sorry, that's my part. All right, for our therapy session, we feature an adolescent client who's 15 years old. This client was diagnosed with major depressive disorder approximately 2 years ago due to their experience of loss of interest in hobbies. They were also lethargic. They had insomnia, and they had low and depressed moods, and they had feelings of exclusion, worthlessness, and emptiness. This resulted in the client partaking in substance use, particularly with the use of cannabis. They've gone to therapy twice, so this video that we're going to show you is from the 3rd session. The reason why they're in therapy is because your parents have noticed that the client is using substances, along with the fact that the parents are on the verge of separating, and so they had decided to place the client in therapy, hoping that this would resolve the issues. Also, the client is the only deaf person within a school full of hearing people. They don't have very much involvement within the deaf community. They also used to pursue artistic interests such as arts and crafts and storytelling, but they have stopped due to lost interest. Now we're going to talk about the therapy techniques, which are art expressive therapy and free association. I'll go ahead and explain what they both mean. Art expression therapy is just focusing on creativity for your own self-improvement and growth and healing. Free association, however, is more of whatever thought pops in your mind, you're just going to go ahead and throw it out there without any hesitation. Just go ahead and say it. And this therapy now is going to focus on the both of them so they can deeply process their thoughts, what's going on behind them within the unconscious mind. Basically, how it would work is you can give a client a piece of paper, and normally with free association, you would just write stuff down for about 5 minutes, and you're really not thinking too much about it. You're just writing down whatever you think, and then after 5 minutes, they stop. But in this case, they're going to be doing drawings, and then after that, you can go ahead and talk with them to figure out what the possible meanings are behind what they drew. All right, we hope you enjoy. All right, our session had shown one cognitive distortion and one cognitive distortion and one defense mechanism. The cognitive distortion is minimalizing, which is basically kind of saying like, oh, something isn't that bad, it really didn't hurt me, or minimizing the negative effects of something and emphasizing the positive effects of something. The defense mechanism was displacement, and the reason behind that would be if someone is, using cannabis because they're stressed, they're angry, and then they start blaming other people, such as their parents or perhaps even a therapist. Maybe they feel like they don't belong or they feel worthless or something, and that express their anger onto other people.